Let's go ahead and get started. So this will be the first live session of our four-part series, Biostatistics and Evidence Appraisal for Radiation Oncologists. And just a reminder to everybody, this is going to be recorded and going to be posted on the RockSig website. And so thank you to Bailey Nelson, one of our residents, and Kara Leonard for helping to organize the series. And also thank you to our chair, Dr. Barrett, for helping to support this. And so I'd like to introduce Dr. Prasad for his talk on clinical trial design and endpoints. Dr. Prasad is Associate Professor of Medicine in the Division of Epidemiology and Biostatistics at UCSF, also a practicing hematologist oncologist. His research focuses on cancer drugs, health policy, and clinical trial design. He's authored a book called Malignant, and he runs a very popular podcast called Plenary Session, both of which explore a lot of these topics in great detail. I encourage you to check those out as well. So I'll turn it over now to you, Dr. Prasad. The floor is yours.
Thanks so much for having me. I'm going to talk about clinical trials endpoints. I titled the lecture Thinking Better About Cancer Drugs, and I think it goes beyond cancer drugs, cancer medicine, but you all will be the judge of that. In terms of disclosure, I'm the author of these two books published by Johns Hopkins University Press. That's why I'm independently wealthy. I am the host of a popular podcast among a certain brand of recluse, which is Plenary Session. And you can find me on Twitter at that. I'm going to talk to you all about progression-free survival. Is it meaningful or is it simply measurable? I want to talk a little bit about crossover. And if we have time, I'm going to talk about non-inferiority. I think it's helpful to think about these kinds of questions with a case in mind. This is a real composite of a couple people I saw many years ago. This is Mr. Jones. It's as close to the real story as you can get. Mr. Jones was a 75-year-old gentleman who complained to his PCP that he had had some intermittent epigastric pain, some sharp stabbing pain, and a 5-pound unintentional weight loss. So what do you think his PCP did? This was a few years back. It's about a decade ago. His PCP did the only thing that a PCP should do, which is threw him in a CAT scanner. Threw him in a CAT scanner instantly, based on that unintentional workup. And in fact, it was a prudent move because he found this on the CT imaging. So I think many of you who spend a lot of time, especially since you're all radiation oncologists, you spend a lot of time looking at imaging. I think it's all obvious here. The head of the pancreas is enlarged and there are a couple of liver lesions. The wizards in IR, they were able to stick a needle into it and they biopsied one of the liver lesions and it came back as well-differentiated pancreatic neuroendocrine carcinoma, a non-functioning PNET tumor. This is a tumor that we see from time to time, of course, by no means the most common type of pancreatic cancer, a rarer subtype of it. But my understanding is the subtype that Steve Jobs unfortunately suffered from. And I saw this gentleman back in 2010, so this was about a decade ago now. And back in 2010, I know for the junior physicians that feels like a lifetime ago, but we were quite similar to the way you are today. We did the only sensible thing when we were confronted with a case of a patient, which is we turned to the NCCN guidelines. We just went ahead and followed that flow chart to tell us what to do, which is still the brand of medicine that is most favored amongst, I think, most oncologists. We looked at NCCN. And while we were looking at NCCN, it turned out that after this CAT scan and the biopsy, the patient said that actually, you know what, that epigastric pain, it started to feel a little bit better. It didn't come and go anymore. And when it comes to that unintentional weight loss, there might have been some measurement error on some of the scales, and he wasn't really sure he lost weight at all. And so by the time we looked at the chart, the best story was that this gentleman had local, regional, or unresectable PNET with distant metastases, but he was really asymptomatic. And you can argue about the amount of tumor burden, but he was asymptomatic, and we had no sense of the tempo of his disease. So based on his symptoms, the fact that we had a couple of liver lesions, that there weren't terrific options back in 2010, we were staring down the barrel of cytotoxic therapy. We decided to observe this patient with markers and a scan, see him really, really closely. And we saw him in a clinic that specializes in neuroendocrine tumors. So we saw him and, this was his baseline scan. We saw him again 3 months later and we saw him again 3 months later. And, it really looked the same. It looked like it hadn't changed a whole heck of a lot. There may have been a slight difference based on the plane at which he got sliced in the CT scanner, but it was mostly the same. And a year later, I think this was 2011, he came to me and he said, good news, doctor. All this time we have been anguishing about how to treat me. You were debating between watching me or giving me those old-fashioned cytotoxic drugs that nobody likes. There's good news. Now there's a third option. There's the perfect option. And here's the perfect option for the patient. It was the Oncology Drug Advisory Committee meeting approving everolimus for the treatment of pancreatic neuroendocrine tumors. Everolimus, of course, an inhibitor of mTOR, and a targeted drug. And since it says targeted instead of cytotoxic, I think many people interpret that to mean better tolerated. Whether or not that's true is another story. But it was approved for PNET with a 10-0 vote. You don't get many unanimous votes in this world. Here you have one, 10-0. Benefits outweigh risks, clear as day. And this is why. This is the progression-free survival in the study. Everolimus, placebo. I know many of us who practice oncology, we were told that if you can fit a laser pointer between the curves, you can give the plenary session of the national meeting. Here, you don't have to go try so hard. You can easily see, you can fit your whole thumb between those two curves. And the hazard ratio, look at that, 0.35. Spectacular. I don't know exactly what a hazard ratio is, but I know that's a good number for a hazard ratio, a good number for one. We like low hazard ratios. How to explain it to a patient, that's a challenge, but lower is better. And that's a good hazard ratio. You don't see them that good too often. So this looks quite good. PFS, big benefit from everolimus versus placebo. Overall survival was a different story. It is often the case in oncology, it's a different story. And here OS was entirely superimposable. Hazard ratio 1.05 with a confidence interval that's quite wide, very wide confidence interval, P 0.59. There's no way I can spin it. There's no way I can spin it other than to say the overall survival is not mature. So it's eventually going to be positive, but not yet. It's not mature. And in fact, that's what the company was saying. It's just not mature enough, even though, of course, we have the survival function reaching about 65, 70%. Not mature. There are not enough events. Who knows what might happen in the future? Something we like to say in oncology. So the NCCN, they don't waste any time at all. They quickly threw in everolimus and sunitinib right there in the algorithm. It is an option. We have options, and now we have some new options, and it's a targeted treatment option. I didn't tell you, but of course, Pfizer's drug sunitinib was also up at the same ODAC. They both made it based on PFS. And, we scanned the patient again, and I don't know, call me crazy, but isn't that a little bit bigger to you? And if you ask the patient, maybe he is feeling a little bit more satiety, a little bit more fatigue. It's hard to know. But with this new option out there, maybe he is. Maybe he is progressing slowly, but surely. Maybe he is a good candidate for this drug. So Mr. Jones asked me a question I get asked often, which is, should I consider everolimus? And I said, my job as a doctor is never to tell someone what they ought to do. It's merely to help them make the choices that are right for them. So here's how I would think about everolimus. I always ask when I think about any drug or any radiation procedure, is there clear evidence that by doing this will improve overall survival? And I guess in this case, I have to say, admittedly, there is no clear and convincing evidence we're going to improve OS. In fact, if you look at deaths on treatment, there were 12 patients or 6% in the treatment group that died while on study, and only 4 in the placebo group or 2%. So there's an excess in deaths while on study drug in the treatment group. We don't know what improves survival. We know that there are some rare AEs that are troublesome. So, does it improve survival? The best answer is, I don't have evidence for that at this moment. The next question I always ask is, what about quality of life, And we don't have a clear signal, and I don't think quality of life was reported at this time, but we knew a few things about everolimus. It increases your rate of stomatitis. It increases it quite substantially. Rash is more common, diarrhea is more common, fatigue is more common with everolimus. So it is more common than placebo. It has all those side effects. So, a drug with real toxicity, real cost, I think it was $7-8 grand a month, which back then was the going rate. But these days, we're 12-14 grand easy a month. No survival benefit, but it does have a PFS benefit with a hazard ratio of 0.35, which is really low, so I'm told. And Mr. Jones asked a good question, which is, what the heck is PFS? What the heck is PFS? You keep saying PFS. Oncologists, all you say is PFS. I don't have a clear idea in my mind what that is. Can you explain it to me? I said, I'm happy to. I said, imagine tumors at baseline, those scans that we looked at and we can measure it. And I like to say, measuring a tumor on a CAT scan, I wish it were like measuring your height. It's a lot more like measuring the width of a cloud between your fingertips. We can disagree about where it begins and where it ends. I think there's a little bit of disagreement there. And in fact, studies would show that that is the case. And progression-free survival is a time-to-event endpoint. It requires Kaplan-Meier method to plot it out, the time to event. It's the time until something happens. So what is that something? Well, it's the time until a composite endpoint happens. It's the time until one of several things happen. So here are those several things. The patient could pass away. If you start in a clinical study, 2 weeks later you die, you have been scored as the PFS event, and that's a very unfortunate outcome. We don't want this for anybody. The other thing that could happen is there are new lesions on scans. We scanned Mr. Jones in his chest. There was nothing in his lungs that struck me as abnormal. But let's say 2-3 months down the road, there was a couple nodules and we needle biopsy those and those were peanut. Lo and behold, that is progressive disease. New lesions on a CT scan, that's scored as an event. We don't want that for anyone either. The next thing that could happen is the tumors could get bigger, but not just any amount bigger. They got to get beyond a certain point bigger, of course. They have to exceed the unidimensional measurement of 120% diameter. 122% and you unfortunately have progressive disease. 119% and you're blessed to have what we call stable disease. It's as stable as it comes, even though it's 19% bigger and headed for 121%, but it's not yet progression. Do patients come into our office and they say, I feel good, I feel good, I feel good, 116%, 17%, 18%, 19%, I feel good, and then 122, I feel bad, oh, I feel terrible today? And the answer is no. The cutoff does not define when people feel good or feel bad. Some people feel bad long before they hit progression. Some people don't feel bad even beyond progression. It's not the marker of how you feel. And then the fourth thing that could happen, the fourth PFS event, is he could have tumor shrinkage first. And if it shrinks more than 30% unidimensionally, that of course is a response. 29%, and again, you have what we call stable disease. 31%, and you have RECIST 1.1 response. That's a PR. And then progression is 20% from the nadir value, the smallest it ever was. So it is this fourth endpoint. So progression-free survival, a time-to-event composite endpoint, Mr. Jones. The time until one of four things happen. Could pass away, God forbid. There's new lesions on the scan, God forbid. The disease slowly and relentlessly gets bigger and it tips over that arbitrary threshold progression, or it shrinks and then it gets bigger. This is also the reason why if I do an uncontrolled study of individuals in cancer medicine, which is quite popular, and I administer some drug and it has no responses, it just has stable disease. But the authors proudly say the median PFS was 11 months. That's really good. Well, of course, if you select patients with slow growing tumors, that you can give them sugar water, and some people will have a median PFS of 11 months because it just takes 11 months for their tumors to get 20% bigger. It doesn't tell you anything about the drug. Tumor shrinkage is a measure of drug activity. It is a measure of drug activity. An improvement in PFS in a reliable randomized control trial is a measure of drug activity. Efficacy is a measure of living longer, living better. So overall survival or health-related quality of life or patient-reported outcome, that is clinical efficacy. These are surrogates, response and PFS, for clinical efficacy. And we should not confuse the two. So I summarized to Mr. Jones, PFS, it's something we can measure. It depends on how often I scan you. I didn't show you this, but if I scan you more frequently than less frequently, the bins of the stair step of the PFS shape will change, and it may or may not cross significance. So it depends on the frequency of scans. Different people measure it differently. There are a number of studies that you take the same images and give them to different people. You take the same person, you run them through this CAT scanner 15 minutes apart, and you will find differences in tumor size. It is not a measure of how people feel or function. It is a composite time to event endpoint. So Mr. Jones asks a good follow-up question. He says, you know what? You said a response was 30%, doctor. I heard you, that it's only considered a response if it shrinks 30% or more. It sounds arbitrary to me. Why isn't that 40% or 50%? Do you mind explaining to me where those numbers come from? And I said, wow, I will get back to you on that because, well, who knows where they come from? This is a clinical fellowship. I got to go look that up when I'm done with fellowship. I'm too busy now. So eventually I looked it up, and this is where it comes from. There's a Mayo Clinic oncologist named Charles Mortel, a very interesting figure, one of the first to oppose the lofty and unsustainable price of drugs. And in 1976, he invited 16 oncologists to participate in an experiment. He had 12 spheres and they took 1,900 measurements. So that's what they did in 1976. And a senior investigator at NCI told me, apocryphally, that this was a dinner party at Mortel's house. I've never been able to verify whether or not it was a dinner party, but it could have been a dinner party. And what did Mortel do? Mortel got 12 marbles and they ranged in size from 2 to 14 centimeters, the standard issue marbles that you and I probably have in our houses as we speak. He put them on his table and he rolled out foam rubber. He rolled out 1/2 inch of thick foam rubber to approximate the skin and subcutaneous tissue, and a 1.5 inch thick foam rubber to approximate the abdominal masses. And each of the 16 experienced oncologists was asked to measure the diameter of each sphere using the usual technique that, quote, he employed in clinical practice. Yes, unfortunately, it was he employed. And that's because this was a gender-biased era. There were only 16 men who were doing this. So what was going on here? 16 men, they had calipers, they were measuring marbles through foam rubber and writing down the size. And there was one more trick. Mortel is a smart guy. He's very smart in many ways. One way he was smart was 2 marbles and 2 marbles, 4 marbles, 2 and 2, two sets of marbles were the same size. Marbles 5 and 6 were the same size as were 7 and 8. So now Mortel can do something very clever. He can ask, how often do 2 different doctors think the same marble is actually different in size? And how often does the same doctor think the same marble is different in size when they measure marbles through foam rubber? And the answer depends on the cutoff of different. If you use a 25% bidimensional cutoff, then about 1 in 5 times for the same person, we think the same marble is actually different when we use that very tight cutoff. But we use a 50% bidimensional cutoff, then it's only about 1 in 20 or 1 in 5% error rate, which is close to the famous P of 0.05, which R.A. Fisher produced from thin air, which is really produced from thin air. But so it's close to that nominal significance. So that's why he liked that 50% cutoff. This way we can agree the same tumor is the same in size. Let me ask a question for anyone out there, if anyone is out there, who knows. Why does Mortel have people measuring marbles with a caliper through foam rubber? It's the way they're measuring the quote-unquote tumor. The marble is supposed to be the tumor. What do we have that Mortel doesn't have?
Cross-sectional imaging.
Yes, Mortel does not have imaging. Boy, it's pretty hard, actually. You got to give him a lot of credit. Can you imagine taking care of a pancreas cancer patient, pushing, how hard do you have to push on their belly to even try to palpate the tumor? I can't even tell you if I've palpated a pancreas tumor, and measuring it with calipers to see has it shrunk. And that was the limitation of the day. Mortel is doing a study that is a very practical study for the era that Mortel lived, which is an era where we don't have cross-sectional imaging, and the only way we can measure tumors is by calipers through foam rubber. And he used 1.5 inches of foam rubber to approximate the abdominal wall in an era where the BMI was a lot lower than it is today. We'd have to use a significantly more foam rubber, I would suspect, based on the US BMI over the years. But this was a practical study. Mortel chose 50% bidimensional measurement as the standard for response because it could be reliably detected by 2 different doctors with calipers through foam rubber and the same doctor measuring the same tumor through foam rubber. This was a cutoff chosen for operational reasons, that it made sense. We could use it as such. And it was never intended to be a metric of efficacy, and it has become synonymous with efficacy. Mortel was devising response rate as a way to screen candidate drug compounds for anti-cancer activity. He didn't want to do randomized trials of every compound. He wanted a way to tell that we'd only screen the drugs that could shrink tumors. And that was why it was developed. It was never developed as a measure of efficacy. It has since become hijacked as a measure of efficacy. Mr. Jones is a good student because he said, whoa, you're pulling a fast one, doctor. Mortel has figured out 50%. You said the cutoff was 30%. So you're pulling a fast one. What gives? Well, it turns out that the original WHO 1981 criteria used bidimensional measurements, measuring 2 sides, 50%. And of course, when we codified it into RESIST, we went to a unidimensional 30%. And the reason that makes sense is that if you do that math, 4/3 pi r cubed, roughly that is the same volumetric change in the sphere. So that's why we have 30% today. So, response rate. Good metric or great metric? No, it's a very arbitrary metric. Very arbitrary. I think we forget how arbitrary it was. We think of response like it's some miracle thing. And of course, shrinking tumors and dramatically shrinking tumors often makes our patients feel better, but there was never any magic to that 30%. There was never any magic there. So Mr. Jones says, no wonder PFS doesn't capture how I feel, but, surely drugs that improve response rates and improve PFS extend lives. That has to be the case, isn't it? And I would say, well, I'm a believer that a drug that does not have any activity, that it has no single agent response, is unlikely to improve survival. Although I read stories to the contrary about things like vitamin D and coffee, which apparently in colon cancer, according to a new study, massively improves survival, even though coffee has never shrunk a tumor ever. So I'm a skeptic of those claims, but just because it shrinks the tumor doesn't mean you live longer. Let's look at that question. We've done a number of umbrella meta-analyses looking at the question, do drugs that delay PFS later improve OS? Now, there's a common misconception here, which is somebody might say, let's just pick on MRD, minimal residual disease. Somebody might say people who achieve MRD negativity, they have a longer OS than people who don't. Well, that only validates MRD as a prognostic marker. To validate it as a surrogate, you have to ask this question. In randomized trials of drugs that seek a regulatory approval, do drugs that improve the fraction of patients that achieve MRD later improve the overall survival amongst those patients in a randomized setting? It is an entirely different question. And let me try to walk you through that language in a very visual way so it makes sense to you. Imagine I want to ask the question if progression-free survival in frontline metastatic breast cancer is a good surrogate for overall survival for drug approval. This is the Avastin in breast cancer kind of question. The way I would ask that question is I would compile every randomized controlled trial ever done in this space. Let's just say hypothetically it's 2. It's not 2. I think the reality is it's closer to 222 rather than 2, but let's just say it's 2 to make the math easier. One randomized trial, we randomized people to, Avastin plus or minus Xeloda versus Xeloda, and this was the PFS difference, this was the OS. In the other randomized trial, we randomized him to, taxane or something else, and this was the PFS difference, this is the OS difference. I plotted out. Each randomized controlled trial is one dot on a scatter plot, and I plot on one axis the delta or hazard ratio PFS, and on the other axis, the delta OS, and then I perform linear regression. And linear regression is literally asking how the R coefficient or the R squared, the coefficient of determination, is literally asking how close do the dots cluster to the line. The R squared coefficient of determination is literally telling you what percent of the variability in change in survival is captured by the variability in progression-free survival, the change in PFS. And the answer is you want most of the variability in the endpoint you care about to be captured by the surrogate endpoint in clinical trials of drugs in this space. This is the surrogate validation question. Can I reliably deduce that a drug will improve OS based on what it does to PFS in a randomized setting? And the German IQWiG, which is their quality and safety group, don't ask me what it stands for. I don't speak German. They have issued these cutoffs of R, or correlation coefficient, to denote strong, medium, or weak surrogacy. Okay, so they pick these values. You may think that an R of 0.7, you're calling that weak, my friend? That's actually quite good. I'd love to get an R of 0.7 in my research. I would advise you that what that literally means is that half of the variability in the clinical endpoint is unexplained by variability in the surrogate, and that would potentially mean the approval of many, many, many drugs that do not actually make people live longer, live better, if you were to use such a weak surrogate. And that's why they call it weak. So we did this. We looked at every single person who had ever done this, ever. I mean, pretty much every surrogate validation study in cancer, every tumor type, all times we looked at it. And here's what we find. This is just a part of our figure. It's too big to fit on any screen. This shows you on the x-axis time, the year in which the validation study was performed. The vertical axis shows you the setting: colon cancer metastatic, breast cancer metastatic, colon adjuvant, non-small cell metastatic. In the adjuvant setting, of course, we don't use PFS, we use DFS, or disease-free survival, which is a slightly different time to event composite endpoint, acknowledging we don't have lesions at baseline to measure. The diamonds, the size of the diamond is proportionate to the number of data points in the validation study. Something really small like this, I think, is 4. When you start doing regression with 4 data points, somebody might take away your license to use Stata because there's some question mark about whether or not you ought to be doing that. But the biggest ones here are, we're talking about 100 and 150, 200, that kind of ballpark. And that's quite good, actually, to do regression. The color is telling you the correlation coefficient. Yellow is medium, green is good, and red is not so good. And I think you see a couple of things that jump out at me. 1, there's a whole lot of red. A lot of these surrogates are not reliable. 2, there's an enthusiasm for validating surrogates in recent year. Surprise, surprise. When the FDA is willing to accept surrogates, we want to validate surrogates. We are hungry for surrogates because surrogates put food on the table. They literally lead to more drug approvals. And so there's a lot more effort in recent years than there were in the past when almost nobody was doing this work. Another way to look at it is this way, which is in the metastatic setting. Does response rate or PFS predict OS? That's shown in the blue bar, and most are low, few are medium, few are high. In the adjuvant setting, it's more of a mixed bag. 3-year DFS in colon, 2-year DFS in lung. Those are pretty good predictors of subsequent OS. One caveat, this validation is only true for the classes of medications investigated. In this era, it was almost exclusively cytotoxic drugs. So I would be reluctant to extrapolate an adjuvant signal in lung cancer seen in an era of cytotoxic drugs to something like osimertinib, a targeted drug, because we don't have a validation study for the targeted mechanism of action, which may not eradicate microscopic disease, but may merely slow tumor growth and delay recurrence, not avert recurrence. So why don't I just look out into the audience, who are faceless because they has their camera on, and just get a sense of where we are, what we've come. Okay, okay, good. So where have we come so far? I guess so the patient is thinking about this decision. We still haven't gotten to the decision yet. Should he take everolimus for his PNET? We talked about where PFS comes from, where response rate comes from. I hope I've convinced you that they are surrogates. They're arbitrary. The cutoffs are picked, for operational reasons. We do, and then the question is, of course, does it predict survival? So here's where we are. Generally doesn't predict survival. One more thing here. If you approve a drug based on tumor shrinkage, or if you approve a drug based on delaying PFS, in 5 years on the US market, does it ever show survival benefit? This is analysis we did of 36 surrogate drug approvals. We find about 16% of the time these drugs prove survival benefit, but the remainder of the time they either have a randomized trial that does not find a survival benefit, or they have never reported a randomized trial that's ever reported on survival. So the majority of these drugs that are approved based on surrogates, we just don't know a few years later. We never know, actually. We just live with that uncertainty as to whether or not they improve OS, I guess ever. We just never, ever, ever know. And that to me is a problem of drug regulation. Okay, so back to our patient. It has been a whirlwind for Mr. Jones. Okay, so Mr. Jones, he's still thinking about it. He had 1 year of rather slow tumor growth, finally just tipped over the progression threshold. Of course, we knew about a new drug, so maybe we're a little happy to call progression. I told him, everolimus, no OS benefit, no real quality of life benefit, more toxicity, more stomatitis. PFS actually generally doesn't predict OS benefit. And by the way, Mr. Jones, for neuroendocrine tumor, there's never ever been the validation study ever. So what do you think Mr. Jones decides to do? Okay, we have to do some vote now. Somebody, I have to see that someone is alive on the other end. So who wants to shout out? What do you think he decides to do? No survival benefit, toxicity, PFS generally doesn't predict OS, and we don't know in this tumor type. What does he decide to do? I'll tell you what, is a right answer. There's only one answer. This is America. What does he decide?
Opinion.
Opinion. Yes. He doesn't need a second opinion. He knows the answer. The answer is, here's the answer. Let's give it a try. Let's give it a try is the answer. Come on. We always say, let's give it a try. That's always the answer. Doesn't matter how much it costs or what the toxicity is or how few people they have studied it. It doesn't hurt to try. We just try and we just see what happens. And so that's what he did. He said, let's give it a try. And he said, let's give it a try. I want to explain a little bit why PFS might not predict OS. I think it's tricky. I've shown you empirical data that shows, as a matter of fact, it does not predict OS, very rarely. Why might it not? This is another trial of everolimus. This is everolimus plus exemestane versus placebo plus exemestane. This is breast cancer, metastatic breast cancer. There's a PFS benefit here. You'll agree with me there. The hazard ratio is 0.43. Good hazard ratio? What do you think? Good. I think people think it's good. Is it actually good? Who knows? Yeah, but people would say that's a good hazard ratio. This was a plenary session, and I was presenting this. If I was the person who presented this in plenary, which was either Sandy Swain or Jose, I would say the combination of everolimus plus exemestane is a clinically meaningful improvement in progression-free survival, extending PFS from 2.8 months to 6.9 months. The hazard ratio of 0.43 shows a remarkable therapeutic effect, and this drug should immediately be the new standard of care, miracle revolution, game changer, and cure. How do you like that? That's the plenary session. Okay. So this trial, if I were to tell you, actually in the long-term follow-up to this study has shown no survival benefit at all. There's no OS benefit. It just improves PFS. So why does it improve PFS? Doesn't improve OS. Here's a clue. How many, what is these numbers? They always have these numbers at the bottom of these Kaplan-Meier. What does this even mean? So 485 people started this randomized trial in one arm, 239 in the other arm. At time point 1 or 6 months, 400 people were at risk in this arm, okay? How high would you think this curve is right here? Give me a percentage. Someone shout it out. Unmute yourself. How high is this? How high is the everolimus arm? Somebody get a calculator out first. Somebody's gonna shout it out. Somebody get a calculator. How high is this? I lose my mouse.
87.
90%.
Okay, someone says 90, someone says 87. I'm going to take 87. So somebody do 0.87 times 485. 0.87 times 485. What's that?
421.
421. Yeah, 420 something. 420 something. And so what I'm saying is that if 485 people started the study, 6 weeks, I'm sorry, this is not months, this is 6 weeks into the study, 87% of people have not experienced the event of interest. That's supposed to be 420, but it's 398. Where are those missing 22 people? Where are those 22 people? Where did they go? What happened to them? They disappeared. Huh?
They're on their couch.
Under the couch? They probably are at the couch. Censored. Somebody said censored. Somebody typed censored and somehow it showed up on my screen. Okay, the answer is they're censored. What the hell is censoring? Here's what it is. If you run a randomized controlled trial, you never ever get all 485 people the first year you open your study. Of course not. We don't just have 485 people present de novo metastatic breast cancer right that moment. They enroll over time. And actually, if you look at randomized studies, they enroll a bunch in the first year, but a lot more in second year and third year because it takes us a while to get going. Let's say I do a randomized control trial and I look at the data in 2018. The red are the years I enrolled and the blue is where I'm looking at the data. This person has 3 years of follow-up. This person has 2 years and this person has 1 year. And the person who enrolled just 4 weeks ago, only have 4 weeks of data. And what the Kaplan-Meier method does is it censors people for time points who do not have data for them. And it averages the events amongst the people you do have data for. In other words, it assumes that what these people experienced in their third year of enrollment would be what these people experienced in their third year. They just haven't gotten there yet. That these people are no healthier, wealthier, or wise than these people. And therefore, I can assume that if 10% of these people progress between year 2 and 3, 10% of these people and 10% of these people would progress between years 2 and 3 because they're no healthier, wealthier, or wiser. That's the assumption of the Kaplan-Meier method. It's a maximal information harvest. And when you don't have information on people because they enrolled very recently, you assume that they would have the same event rates of people who enrolled a long time ago. So the predominant reason people are censored is that we haven't followed them that long. This is true for overall survival. But for progression-free survival, there is an additional reason why people are censored. It's not just that you haven't followed them that long. What is the other reason why you would censor someone for a PFS curve, but not for an OS curve? One assumption here, with OS, I can always figure out if they're alive or dead because I can look up their social security number or call their family. For PFS, what's the other reason I have to censor them from the data besides they enrolled recently?
I lost the follow-up.
Yes, they didn't get their scan. They didn't get that scan, and they didn't get it at the time point. Look at the shape of the curve. Here, 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 here. Why is it always falling on the 6-week mark? Because that's when they tell them you got to get the scan. Actually, they probably say 6 weeks plus or minus what, 3 days, 5 days? That's how they do it in these trials. So they're all progressing here and here and here. And the other clue here is the little tick marks. Tick, 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 tick. Those tick marks are a lot. Those tick marks are censor marks. So those are people getting censored. People are censored for progression-free survival, not only because they enrolled recently, but also if they stop coming for the scan. Why do people on a randomized trial of a novel cancer drug stop coming for the scan? What are some of the reasons?
Too sick?
Yes. They don't like what you've given them. You've given them some lousy drug that gave them stomatitis, and they don't feel good, and they aren't coming for your scan, and they probably have some words for you, choice words about what you did to them, and they may not show to your scan. And so you censor them. Now, who are you censoring? Are you censoring somebody who has the equal probability of experiencing the event as the people who show up? Are they equally healthier, wealthier, or wise? Or are you censoring them in a different way, potentially? You're censoring who? Who are you censoring? Let me give you another way to think of it. Imagine I do a randomized control trial, placebo exemestane, low-dose atropine exemestane, low-dose atropine. Low-dose atropine, is it fun to take or slightly miserable to take? I would say slightly miserable. If I give low-dose atropine to 485 women with breast cancer, who is the one that I'm going to keep out of my clinic? Is it the 48-year-old woman with metastatic breast cancer or the 68-year-old woman with, borderline ejection fraction, a hint of diabetes, who's older and frailer? Who's the one I'm going to knock out with my little bit of whiff of atropine? Older,
68-year-old.
The older, frailer women. So what's my point here? My point is there is censoring in this trial. There's a lot of censoring. It's early. Early censoring makes me suspicious that something is going awry. There's more censoring in the everolimus arm than the placebo arm, not just numerically, but actually but by percentages. And I do not believe that censoring is occurring at random. I fear that it is occurring in a intentional way. What we have here, I worry, is we have differential, i.e. a difference between the two arms. Informative, the censoring that's occurring is not occurring at random, so it may inform the outcome, and it's preferentially the everolimus arm. What does this mean? Well, that sounds like a crazy theory. What could that possibly mean? So I told you, PFS in this trial, no OS. Many reasons have been offered as to why that occurs. One, the classic reason, of course, is this thing people call post-protocol therapy. Post-protocol therapy was so good that, it all evened out at the end. If people really say that and believe that, then isn't the answer like, well, why do I need to give your costly new drug? Like, why do I need to give somebody a 12 grand a month drug if the post-protocol therapy is so good that they live just as long anyway? It's kind of an argument against the drug, but it's a common argument. But the other possibility is that the PFS benefit you see is a spurious benefit driven by censoring and not by drug effect. And here's how you can look at that. Usama Bilal was an epidemiologist at Hopkins, and he digitalized that curve. He took all the data in that curve, and he used the computer in a fancy way to extract the data and figure out the numbers who are censored at every time interval. And the Kaplan-Meier assumption is that the censored patient is equally likely to experience the event of interest as the person who wasn't censored. And that produces the Kaplan-Meier estimate, which is the big red line, everolimus, and the blue line, the big blue line in the middle, that's the placebo. That's the Kaplan-Meier estimate. But the assumption of the KM estimate is that those patients are equally likely to experience the event of interest. Usama Bilal distorted the assumption. If he assumes that the people who were censored were never going to progress ever, happily ever after they will live, that's this line. If he assumes that they were going to progress immediately after being censored, that's that line. And the same for the placebo. The curves for the everolimus arm splay wider than the curves for the placebo arm. Why does this splay wider than this? I already gave you the reason. Why does the possible outcomes with different censoring assumptions for the everolimus arm broader, wider than the possible outcomes for the different censoring in the placebo arm? Any guesses?
You have a typed answer from Punita. More patients censored in the everolimus arm.
More people, yes. Punita is right. Punita is right times 2. Yes, that's right. The answer is that more people are censored. And since more people are censored, the range of possible outcomes is wider. Now, the key point here is, of course, that the curves can cross, can they not? By making different assumptions about the censored patients, we can show that the curves cross. So what does this prove? Does this prove that the PFS benefit in the absence of OS in Bolero 1 is due to an imbalance in censoring? No, it does not prove that, but it shows that it is possible that this discrepancy is attributable solely to an imbalance in censoring. It doesn't prove it is, but it's within the realm of possibility. Now, we would know, of course, if my good friends at Novartis would give me all the data to the trial and I could look at it, but of course, I'm sure they don't want to give me that. So this is just a hypothesis, but I think it is a hypothesis that we have been developing and doing a lot of studies on. This is another way we looked at it. In the years after this Bolero finding, which was first brought to my attention by Tito Fojo, a professor at the NCI. We petitioned the Lancet journals to explicitly report the number of people censored at every time point. You know, we had to do that 0.87 in a calculator. Why the hell do we have to do that? They should actually say right there under the x-axis how many people are censored. Make it easy for us, right? And in fact, they started doing that in the Lancet. And then Kate Rosen, my medical student last year, and Emerson Chen, faculty member who I take credit for because he's good and worked with me, junior faculty. We went through all the Lancet studies we could, and we plot the censored people by arm and the imbalance over time. And what I want to show you is that a lot of trials actually have, this is early imbalance censoring in PFS. You know, it's actually pretty close. There's slightly more censoring in the control arm than the treatment arm. Why do you think there is slightly more censored people in the control arm than the treatment arm early on in a randomized trial of a cancer drug? Any guesses? Thing, on average, if you randomize people to new treatment drug versus placebo or old treatment drug, more people will be censored in the old treatment drug arm. What's your guess? Why? Let's just say it's a placebo-controlled new fancy drug versus placebo drug. More people censored in control arm. Why?
Did they switch, they cross over, or change to a different drug?
They they drop out. I guess it technically wouldn't be crossover because it's not, they get the investigation drug, but you're spot on. They drop out because they're disappointed. They don't want placebo. Who wants placebo? Nobody wants placebo except the investigators. You know, they don't want placebo. They know they're getting placebo even in a blinded study. Because why do they know they're getting placebo? Because these drugs are, they're not sugar water. You know, if you gave me everolimus or sugar pill, I promise you I'll figure it out real quick. Which one's which. And they figure it out real quick. On average, there's a slight imbalance. They drop out. So that's a problem. Look at this trial over here. Look at that. Let me ask you something. If you saw one trial with this massive imbalance in censoring, would you be very happy with it or suspicious of it? Happy or suspicious? That's the choice.
Suspicious.
Suspicious. And in fact, you should be suspicious because this is quizartinib, which went to the Oncology Drug Advisory Committee meeting, and the FDA reviewer detected this massive difference in censoring that was really, really obnoxiously different, and the drug was rejected almost solely on the basis of that fact that so many people were censored that they're not really sure the resultant Kaplan-Meier estimate is a faithful estimate of what would have happened to people. You see my point. So this is a very useful thing to do. We published this in Journal of European Journal of Cancer. It's a very technical paper. Oh, shoot. So let's go back to Mr. Jones. Mr. Jones, of course, let's give it a try. You remember that was the last thing we said. We said, let's give it a try because that's what we do in oncology. We try. There's nothing that we won't try. We'll try it. Why not? Give it a try. 1 month later, he came back after giving it a try, and he said that this is a verbatim quote. He said, he used a word I don't often hear in my line of work. He said, I feel something worse. I didn't used to hear this a lot until they started approving selinexor. Then you hear this phrase all the time. With selinexor, you hear this all the time. But before that, you don't hear this phrase too often. So he felt worse. Okay, next point. Has crossover led us to underestimate good drugs? I think this is the most misunderstood aspect about cancer drug development. I'll go pretty quickly through this, and then we can talk about non-inferiority in the next part. But I think the censoring part is something that will interest you. So years later, oh yes, Mr. Jones, I haven't forgotten about him. I've had him a long time. A couple years later, he came back to me, and we scanned him. Actually kind of looked the same to me, to be honest with you. It didn't really change that much, even though he only had 1 month of everolimus as his only treatment. And he found this. I think he actually went to an ASCO as a patient advocate or something, and then he woke up one morning and in the hotel room, they had hung something outside his doorknob, and it was just like a big bag full of like 100 trees they cut down to make flat leaflets and stuffed it in this bag. And one of those leaflets was this. Look at this. Afinitor, everolimus, the final survival results from Radiant. And look at that. That is, he said, you think you know a lot, doc, but look at you. You are eating your words, my friend, because that is a clinically meaningful improvement in OS. Boom. When I said it wasn't mature enough yet, in fact, that is true. As maturity came, the benefit is there. And the industry has done a great job. They've color-coded it for you, so you can't miss that benefit. 6.3 months. What do I have to say about that? And I said, wow. I really was taken aback. I was like, I'm shocked. I keep track of this as a sort of a obsession, and I had never heard that there was a survival benefit. So how is there survival benefit? I didn't know. So I had to find this ad. I looked all over the internet, and at last I found it. And here it is on the web page. There it is, just as he says, clinically meaningful benefit. Oh, but what's this bottom? What's that say? Not statistically significant, but clinically meaningful. Not statistically significant, but clinically meaningful. Yes. Interesting. In oncology, we're so used to the opposite. It's statistically significant, but nobody would care about such a trivial benefit. But I'm not used to seeing this. Not statistically significant, but clinically meaningful. See, when something's not statistically significant, I call it not something to report at all. And so I wouldn't go further and deem it clinically meaningful and shade in the curves and all of this. This is ridiculous. This cracked me up. No. But the people who make this drug would say it's due to crossovers. What do they mean by that? They say randomized to everolimus or placebo. When the placebo arm has progression, you can get everolimus. And that will diminute or contaminate your signal. And that's why you didn't find the benefit. So what is crossover? We're the only people in medicine who use crossover in this way. Everyone else uses it in a different way. What we mean by crossover is we take people with cancer, we randomly assign them to drug or placebo. When patients on the drug arm progress, they get standard of care. When patients on the placebo arm progress, they get the investigational drug. Boom, cross right over, just right over there. Boom, move them right over there. So in other words, drug, standard of care, placebo, drug. Clear as mud. I think the reason we don't understand this is that there are two broad categories of reasons. There are reasons and situations where crossover is desirable. We want it. We need it. Give it to me. And there's situations where it's undesirable. Please don't give it. Don't have it. We don't want it. No, thank you. And we either get it, we have crossover, or we don't get it. Okay? So it's a 2x2 table. If you want something and you get it, and you don't want it and you don't get it, is that good or bad? You want it and you get it. You don't want it, you don't get it. Good or bad? Good. Good. There's someone out there. The difference between insanity and sanity is that there is occasionally a reply on a Zoom lecture. Otherwise, you've lost your mind. You're just talking to nobody. Okay, so good. We agree. Those combos are good. And if you wanted it and you didn't get it, or you didn't want it and you got it, that's bad, right? So let me show you two examples of the bad. So everolimus has crossover, the company says, but I haven't told you, did I want crossover or didn't I want crossover, right? So here's a trial, Sipuleucel T. It's that Provenge cancer vaccine. It's unlike a regular vaccine, which prevents you from getting a virus. It's a vaccine that is given to somebody who already has cancer to get the body to attack the cancer and slow the cancer's growth. The only similarity it has with the regular vaccine is that it's also linked to autism. No, just kidding. No, totally, it's not. It's not linked to autism. Neither have been linked to autism. That's a fact. Okay, so in a randomized trial of Sipuleucel T or placebo, there's an improvement in OS. Come on, this is good, people. Look at this. This is survival, prostate cancer. Vaccine, no vaccine. Come on. That's a 4-month benefit. That's, that's a 22 to 26 months benefit, Come on. You can fit 2 lasers between those curves. I get 2 plenaries out of this. This is a good trial, right? Well, it has some issues with it. You probably are like, what is a cancer therapeutic vaccine? And the answer is you don't need to know it because there's only been one ever approved in the history of humanity. All of the other ones have failed, including one from, the pancreas cancer vaccine failed, the Prostavac failed. They're all failing. This is the only one that ever worked. The drug, actually, the vaccine has no response rate 0.0%. Even Mortel could tell you, feeling through foam rubber, that the marble has not done anything. It has a 0% response rate. There is no time to progression improvement. It has no drug activity, but it has that 4-month OS benefit I showed you. How the hell does it do that? It's a miracle. You give the vaccine, there's a delay, doesn't shrink tumor, obviously. It doesn't that PFS1. You wouldn't want it to anyway, but later it kicks in full blast, gives you the survival benefit, right? That's what people say who like this drug. Let's think about the trial. They randomize people to CYP-T or placebo. When patients progress, if you progress on placebo, what do you get? You have crossover. So you get CYP-T. And when you progress on CYP-T, what do you get? You get docetaxel. And docetaxel is a drug that's a life-prolonging drug in prostate cancer. Docetaxel is a good drug. And if you progress here, you get docetaxel. So is this a trial only T or placebo? Or is it a trial of something else?
Docetaxel.
It's a trial of early versus delayed docetaxel. Early versus delayed docetaxel and CYP-T. And in fact, if you look in the fine print, it says something boring, but basically it says 57% of people got docetaxel here, only 50% of people got it here. They got it after 12 months here, and they got it after 14 months here. So in other words, is the survival benefit in this arm a drug that has no activity, no tumor shrinkage, it has no improvement in PFS, but it has a 4-month benefit? Is that because it is somehow a miracle drug that kicks in after? And by the way, it's the only vaccine that ever worked in the history of humanity, therapeutic vaccine. Or is it because there's an imbalance in post-protocol therapy? It's the docetaxel doing the lifting. And this is the AHRQ from the AHRQ report. We cannot exclude the fact that in the absence of PFS or RR, that the benefit is actually due to harm towards the control group from getting a delay in chemotherapy because they got an ineffective frozen vaccine, is basically what they say. So crossover is undesirable in trials assessing the fundamental efficacy of a therapy. And in the case of Sipuleucel T, you got it anyway. And so that's a problematic. So I don't know if it actually does anything. And it has confounded that estimate. Let me just give you the other example. This is the trial of abiraterone or placebo in castrate-sensitive disease. But it turned out that if you got placebo here, we already had 2 randomized trials showing that abiraterone is a life-prolonging agent in castrate-resistant disease. So these people should get abiraterone eventually. It turned out they never did. And DeBono and colleagues write this in the New England Journal. Before these trials, Latitude and Stampede, the standard of care for people with prostate cancer included sequential androgen suppression with taxanes, Abi, and Enza. The control arms of Stampede and Latitude were not designed to include the current sequential standard of care with life-prolonging crossover treatments. These treatments were not specified in the protocols, and this is critical since the majority of men in these control arms died without exposure to these drugs. Thus, the drugs used in the control groups were inconsistent with prevailing standard of care, and this has implications for the conclusion for all participants. In other words, crossover is desirable in situations where the drug has already proven benefit in a latter line, and you're trying to move it up front. You got to get it to the control arm on the back end. And here, when you don't have it, that's also bad. And we saw that with Latitude. Okay, so Mr. Jones' tumors grow. Back to our patient with PNET, we gave him platinum etoposide. He had a good response. Okay, let's talk about non-inferiority. Then I think we will be done. There are 3 types of study design roughly in cancer medicine when you run a study. There's superiority, there's non-inferiority, and there's equivalence. Superiority asks, is this experimental arm better than the control arm? Non-inferiority asks, is the experimental arm no worse than the margin than the control arm? And equivalence asks, is the experimental arm no worse than the margin, but the margin is very, very tight? Which study design proves that a new drug is not 1 bit worse than the old drug? If you really wanted to show the new drug or new radiation procedure, it's not even 1 bit worse than the old drug, which is the only design you can use. Great question.
Equivalence, I think.
Uh-huh.
Or someone said trick.
It's a good guess. Equivalence. Equivalence would show you that it is no worse than a very tight margin, but it doesn't show you that it's not 1 bit worse. The irony is the only way to show it's not 1 bit worse than the older therapy is actually to do a superiority trial. It's a trick question, yeah. Equivalence is just a very tight margin, but it's still fundamentally an NI design. Okay, so I'll show you that in a second. It's kind of a trick question. Non-inferiority. You only run a non-inferiority trial if your experimental arm is supposedly better tolerated, more convenient, or cheaper than the other older arm. If you have a new drug that is worse tolerated, less convenient, and more expensive than the older drug, why on earth would you do non-inferiority? That's a very foolish thing to do, and yet we see that in oncology. What counts as convenience is a matter of debate. An oral medication may be more convenient than a frequent IV medication, but recently somebody had the audacity to tell me that this oral testosterone suppressing drug, Relugolix, is more convenient than Degarelix. And I said, my friend, a depot injection is more convenient than a daily pill, which is more convenient than a frequent IV drug. But I don't live in a world where I would say a depot injection is less convenient than a daily pill that I have to remember to take. So I think people can fool you about what counts as convenience. So if there's a therapy that is equally toxic, equally inconvenient, and equally expensive, then you shouldn't even run an NI trial because nothing justifies the loss of efficacy. And that's my point. The only way to show it's not 1 bit worse is a superiority study. So let's just have one example. This is pazopanib versus sunitinib, randomized controlled trial of 11,000 people, non-inferiority study. It was run in an era where sunitinib had the frontline market share. This is sunitinib or pazopanib. Just looking at it from across the room, who's doing worse? The trial met non-inferiority, but who looks worse to you? Who do you think ran the study? Who ran this? Who paid for the study? The maker of sunitinib or the maker of pazopanib?
Sunitinib.
The maker of pazopanib. Oh, well, we'll see. We'll see. Because it's non-inferior. Maybe I see. It's a double trick. So they say pazopanib is non-inferior to sunitinib with respect to PFS. The hazard ratio is 1.05, which is not so good. And the 95% confidence interval is 0.9 to 1.22. But the predefined margin, the upper bound of the confidence interval was 1.25. So it squeaks in. It's not worse than 25% worse. 25% worse than sunitinib is really rather lousy. And even 22% worse than sunitinib is really awful. This ain't worse than 25% worse, which is really bad. One way to look at this is you see these kinds of plots that say, if you plot the confidence interval of the treatment difference, how does that look in a non-inferiority study? And if the upper bound, or if the lower bound or upper bound, depending on which way it's portrayed, if it crosses the margin, the pre-specified margin, this is considered inferior. This is a non-inferior study because the bound of the 95% confidence interval does not cross the margin. And superiority is when it doesn't even cross zero. It's clearly superior. And this is where pazopanib would fall. It squeaks in, squeaky in the margin. And over here, it could possibly be a little bit better, but unlikely. Here's another way. This is sort of, I think, a consort diagram of all the ways you could look at it. Superior means it's way better than the zero different, the possibility of no difference. Superior. This is non-inferior because it's above the margin. This is inconclusive because it crosses the margin. So it doesn't rule out being worse than that arbitrary pre-selected margin. Superior, non-inferior, inferior, inconclusive. So I told you which number here is closest to the actual study, pazopanib, sunitinib. It is non-inferior, so that's a clue. It's just above the margin. Which number here is closest to the actual confidence interval observed in the study?
3?
Yes. Who said it? 3. It's 3. Good. Someone's awake. So why did they use NI design? Is pazopanib better tolerated, cheaper, or more convenient? And the answer is, I don't know if I'm going to come to that, but it's certainly not cheaper, and it's certainly not more convenient. So the question is it better tolerated? And who decides what the margin or delta is? Who decides that? So we actually did a study, empirical analysis of all the non-inferiority trials in oncology. I think this includes radon trials too, and asked cheekily, are they good enough? We find that in a general rule, most people do not, there are different reasons given for why they're using the NI design. The most common reason is that they claim to be more tolerable. Our drug is more tolerable. It's more convenient. Many people don't even tell you why. A quarter of people, they don't indicate why they're using the NI design. 11% is more convenient, less costly, but cost is almost never the reason. No surprise, it's oncology. Everything's gonna cost more. What about pazopanib? So they say comparison of safety signals suggested that pazopanib was associated with lower incidence of fatigue, hand, foot, stomatitis, myelosuppression than sunitinib. But interestingly, all of the instruments were administered at baseline and on day 28 of cycles 1 through 9 and day 42 of subsequent cycles. Okay, you all probably don't know this, but I guess I'll just tell you, pazopanib is given continuously, but sunitinib is given on a 6-week cycle where it's on for 4 weeks and then there's 2 weeks off. And patients really enjoy those 2 weeks free of the medicine. So of course they're doing the hand-foot assessment on the 4th week. So basically they're doing 4 weeks of pazopanib, but there's no break, and 4 weeks of sunitinib, and then they take your assessment and then they give you the 2-week holiday afterwards. So it's like asking you, how happy are you with your job, like before you go on vacation and not after vacation. So it kind of penalizes the control arm. One of the things about the margin that we looked at was how often do these do ratio and absolute difference or percent difference or z-score, and these are the answers. How do they justify using a margin? Most people don't justify why they pick. Why is it 1.25 and not 1.2 or 1.1? They really don't justify. Some people tell you in the publication why. It's almost never a good reason. The real good reason is that you somehow surveyed people and said, in exchange for the convenience of depot, we were willing to take a 10% loss of efficacy. We surveyed 1,000 patients to prove that. That's almost never the case. These are the whether it's a 1 or 2-sided alpha level that they pre-specify for the confidence interval. Okay, let me do one more teaching point here, which is when you do a superiority study, we do intention to treat. We do intention to treat because we want to know that something's superior, even if some people don't comply with the recommendation. When you do a non-inferiority study, it's important to do both intention to treat and per protocol. Why? Why is it important to do both intention to treat and per protocol? Let me give you an example. Let's say I have Coumadin, and we've been using Coumadin for AFib for decades. I have a new blood thinner. I want to show my new blood thinner is non-inferior to Coumadin. Why is it important I do both an intention to treat analysis and a per protocol analysis? Why, in contrast with superiority studies, intention to treat is usually sufficient. For non-inferiority, we also want per protocol. Why? What would be the easiest way to show my new thinner is non-inferior to Coumadin? Maybe my question's not more formal. I guess the easiest way is to tell all the people on the Coumadin arm, just don't take Coumadin. You can take it or don't take it, or you don't prescribe it. And so in other words, you can easily show non-inferiority by basically doing a bad job of administering the old drug. And the only way to overcome that you're actually trying to do a good job of administering the old drug, is to look at the per protocol amongst those who actually complied with the medication. So that's one slight difference. So it's a good sort of sensitivity check on your NI trial. And we find that was only done in about half of the cases. Here's the big takeaway. In all non-inferiority studies in oncology, non-inferiority was met 60% of the time. In industry trials, it was 73% of the time. If you start to get to that range, you're running trials where 73% of the time you get the answer you wanted to get, it's getting to be too high. You're really very likely picking very permissive margins, which guarantee that you will get non-inferiority. I mean, here's a good example. If you take a driver's license test and they ask you to parallel park, if you have to parallel park between two cars parked 25 feet apart, it's kind of difficult. But if you parallel park in a spot big enough to fit 3 school buses, it's really easy. So with a very permissive margin, anything will look non-inferior to anything. Even placebo is non-inferior to sunitinib in the original study if we picked a big enough margin. I'll show you one drug example. This is lenvatinib. This is a drug that's, I would argue, more toxic and more expensive and both oral, so no more convenient. And of course, the way it comes to market is non-inferiority, so the design is not appropriate. The hazard ratio, non-inferior margin that the upper bound they accept was 0.08, which is really rather permissive because sorafenib against placebo wasn't that good. So this is retaining 60% of the sorafenib effect over placebo. This effect over placebo was about 2.7 months. So here we're willing to settle for 60% at 2.7 months, which I will tell you is not terrific. They ran the trial. Here's lenvatinib and sorafenib. It was non-inferior. It was not superior. It's just non-inferior. One thing you should know is when sorafenib is tested against placebo in the regulatory approval, it looks like the left. But in a real-world Medicare data set, sorafenib versus propensity score match patients, it looks like the right. What's my point here? People who took sugar pill in the registration study lived twice as long as people who took sorafenib in Medicare data set, showing that the people who enroll on our trials are so much more younger and healthier than the average cancer patient that placebo in a trial is twice as long survival as, real world sorafenib, which is funny, which is why if you did an uncontrolled study of placebo in this study and somebody would say, oh, wow, it's way better than sorafenib in the real world, by those kinds of historical comparisons. So, basically this lenvatinib trial was able to look for a 1.6 month benefit over sorafenib, over placebo in the real world, or sorry, in the trial, which probably would have a real world benefit of sort of 0. Treatment-related adverse events, I think, were a little bit worse in the sorafenib arm. I pulled this information out because I think there's an interesting story here. When it comes to taking lenvatinib and sorafenib, I told you about per protocol and why that's important. It'll play a role here. 40% of people stop the dose here, 32% stop here, 37% with reduce the dose here, 38% with reduce the dose here, 9% quit, 7% quit. So which arm had a higher dose intensity? Which arm got more drug given? These people who had more interruptions. Lenvatinib has more interruptions. Reductions are about the same. Lenvatinib has slightly more withdrawals. Which arm had a higher dose intensity?
Sorafenib. Sorafenib.
Sorafenib. That would be my guess, because there's fewer interruptions, the same reductions, fewer withdrawals. But the answer was, as the one person guessed, they took 88% the starting dose here. They took 83% the starting dose here on average dose intensity. How does that happen? There are fewer interruptions, fewer withdrawals, and maybe 1% more reductions. That doesn't explain it. I'm going to skip this. I'm just going to point out that it has to do with the dosing. The dosing is When you start sorafenib, you take 400 every other day. And when you dose reduce sorafenib, you initially take 400 once a day, which is 50% the starting dose. When you start lenvatinib, you start at 12. And if you dose reduce, you take 8. So the trial was built in a way that sorafenib has bigger stair step down, bigger dose reductions than lenvatinib, which is a way to penalize the older drug. Okay, I'm going to skip that. So the bottom line of this non-inferiority study is okay, one more thing. If you look at all the trials in the sorafenib versus placebo space, in the original study in 2007, they took sorafenib for 5 months. In the lenvatinib for sorafenib study, they took sorafenib for like 3 months. And in the atezo-bev study, they took it for like 2-point-some months. Every new trial of some sorafenib, we give less sorafenib. We're not pushing the dose like we used to. Okay, so the duration of treatment is lower. 60% as good as sorafenib is not very good. The dose reduction penalizes sorafenib. It's not more convenient. It's not less toxic. It's not cheaper. It's really emblematic. Okay, I'm going to stop there. Maybe I'm getting too into the weeds with this example, but my point here is that non-inferiority studies are extremely tricky. Not only do you have to ask yourself why they're doing it, why are they even doing this study? 2, you have to ask yourself, is the margin reasonable? The next thing you have to ask yourself is, are there ways the trial can be run that harm the older drug, i.e. they're more likely to discontinue it, the dose reductions are steeper? All those things will make it more likely to show non-inferiority, which may in fact be a self-fulfilling prophecy if it's too permissive. Okay, I'm going to stop here and take questions. I hope the teaching points of this were response rate PFS, correlation between what matters, a little bit about non-inferiority and some of the tricky things about margin, some things about censoring and why censoring is really important for endpoints that require the patient to show up in the doctor's office in a way that's not so important for endpoints that don't, like survival. But I'm happy to stop, and I'll stop sharing my slides and I will take questions.
Thanks, Vinay. Very, very, very good. I have one question. Yeah, obviously this series is a lot about appraisal in our trainees. How would you advise trainees to critically evaluate non-inferiority margins, and what is a reasonable margin? Yeah, how should they think about that?
Yeah, I mean, why don't I start with that and then talk a little bit more broadly? But the first thing I would say about that is the first thing you should look at is you should ask, whatever, let's say it's procedure X, like radiation versus, a new type of radiation. The first thing you should ask is the control arm of the non-inferiority study, the thing that's the current standard of care. What made that the current standard of care? You got to pull the old paper. So you got to find like how much better was the old radiation versus doing nothing. So I assume that the original study was like nothing versus radiation. Radiation wins. And then there's a new study that tries to show that accelerated, low fraction, or either hypofractionated or maybe hyperfractionated is non-inferior. The first thing you want to know is the benefit that the old therapy had over doing nothing. And what's the size of that benefit? Then I think the next question you have to say is, how much of that benefit are you willing to lose? Are you willing to lose 5% of it, 10% of it, if it's a setting where radiation has a huge benefit? Or is it a curative setting where you might not be willing to lose much of it? And then only then turn to the new study and ask, how much benefit could I be losing based on where this margin is placed? You see what I'm saying? Like the first thing to ask yourself is, what am I even getting from the old therapy? And then how much of that am I willing to lose? And so my point with the sorafenib was, which I don't think I put so eloquently, is that the drug only gives you 2 months of benefit, over a sugar pill. And now you're telling me you're only willing to take 60% of that benefit? At some point, it's not that much, right? We're not talking about a month of benefit. That's really terrible. So I think we have to start with that. We have to say, like, what does the radiation do over doing nothing? And how much of that are we willing to sacrifice? And it might be different in settings where radiation is palliative versus where it's truly curative. And if it's curative, you might be willing to sacrifice less. And then the other thing is you could look to see, like, what are patients willing to accept, and how much toxicity or convenience are you really providing?
I'll ask you another one. On the topic of non-inferiority design, one of the things we're seeing, I think, in our field is conventional radiation versus with IMRT, one example, versus proton therapy. which is more expensive and has some favorable dose distributions. Whether that's clinically meaningful is often the question, but in those modality comparisons, one of the trends has been to run non-inferiority designs with several secondary endpoints of toxicity, and the assumption is might be non-inferiority, might meet that criteria of non-inferiority that you set up, and then you kind of pick one of these secondary endpoints of toxicity.
Yes.
And therefore claim you have a benefit with this. What are your thoughts on that overall? I know the answer.
I guess I'd say, I mean, there's problematic. One of the things we didn't talk about in this lecture was multiple hypothesis testing. If you have enough secondary endpoints of toxicity, some will look favorable by chance alone. So there are randomized trials of protons versus photons going on. Is that the case?
Oh, yeah.
For head and neck cancer and prostate, or for which cancers?
Several, esophageal, a lot of these are led through Energy Oncology Cooperative Group. So there's probably 6 ongoing right now in a variety of settings.
Yeah, I think it's going to be tricky. I mean, obviously the cost is going to be greater for protons. Protons is a technology that's been searching for a home all these years. I think many people, I thought, would have believed that because the side effect profile is better, you can keep people on treatment longer and your cure rate should be higher in some of these settings. But you're saying the running is non-inferiority. I think that might be problematic depending on where the margins are. I would look closely at it. Yeah.
And another question about, Punita has a question.
Oh, yes.
I'll just read it. If one had to go back and design a lenvatinib trial, what would be the ideal trial design?
Yeah, I guess I would argue that it probably should have been a superiority design. You really want to know if lenvatinib is superior to sorafenib. We're only getting a couple months out of these drugs anyway. In the real world, it's even worse. And I think lenvatinib would have failed and it wouldn't have been approved by superiority. I mean, because they had over 1,000 people, they were unable to show it. Now we have atezo-bev versus sorafenib, which does show superiority, but the people who got sorafenib only took it for like 2 months, which is, about half of what they took it in the sorafenib versus placebo trial, which should raise some questions. So I guess when you're really talking about these marginal benefits, I think superiority is what we should aim for. It's a good question. When it comes to keeping up with the literature, I guess that was a question you kind of alluded to. I would suggest the following for the residents. You should pick 1 or 2 journals that you want to keep track of. Whatever the signature radon journal is, and maybe a JCO or maybe a New England journal, but pick maybe 2 journals when you're a resident. And then the first thing I would say is to figure out when that journal has new articles. New England Journal, of course, it's 5 p.m. Eastern Standard Time on Wednesdays, and JAMA is around noonish Central Time on Tuesdays, and JAMA Internal Medicine is Monday, noonish Central Time, and JCO trickles them out. JAMA Oncology is Thursdays. Once you figure out when they come, I think what you want to do for your 2 journals that you pick is to just go and skim the table of contents, and maybe once a week, maybe once every 2 weeks, you pick an article to read, but skim the table of contents the day it comes out. And then maybe keep an eye on Twitter, follow some radonc doctors, and see what people say. I guess what you really want is sort of a way you can incorporate reading articles that you can make as a habit. If you have the idea that you're going to read articles when you go on vacation or when you have a free day, you're never going to read articles because we never have a free day. And eventually, your vacation is like your only escape and you don't want to be reading a stack of articles. I think the only way you read articles is when you try to read articles on a semi-regular basis. And the only way to do that, I think, is to take advantage of the fact that, people are going to be talking about these articles when they come out and have some dialogue. And so say, for instance, you look in your journal and you see an article by, who's the guy who did Saber Comet? David Palma? Yeah. Let's say you see a David Palma article about, oligometastatic radiation. It came out on a Tuesday. You can rest assured that the radoncs on Twitter are going to be chatting about it on Wednesday. And so if you look on the website, you see it came out on Tuesday, you can just listen to the chatter and see what are they saying? What are the kinds of things they read? What kind of things they see? And I think it's a good way to kind of make reading articles, which seem so isolated and boring, to feel more like you're part of the community and keeping up with like the water cooler talk. So I guess that would be my advice for how to actually start reading articles. And then eventually, one day somebody's going to say like, oh, they're censoring this article, and then it's going to lead you down a rabbit hole of your own curiosity. And eventually I think you're going to be really strong at reading articles.
I had a question. For some of the, progression-free survival not being the best surrogate endpoint in some of these trials, would there have been a better endpoint, or are these trials, should they just be interpreted as like, there's no survival benefit and the drug isn't helpful, and should it just be scrapped? Or like, what is the, what purpose, all this money is dumped into developing a drug and then there's no benefit and they scramble to find some surrogate endpoint that shows there's a benefit. So how do we, progress medicine and get good surrogate endpoints and still have incentive for the drug companies to make drugs?
Yeah, I guess I would say that everything about how the trials are designed now is to maximize market share of drugs, bring them to market quickly and move them to front lines with maximum market share based on the least amount of evidence the FDA will accept. I think if you really want the answer to that question, you should read my book, Malignant, or listen to the audiobook, because I'll take you through it. And by the end of it, that question will be answered at a very deep level, how we ought to do things. But I would say that one of the reasons why we use PFS instead of OS is people say that it takes too long to have OS. For instance, in frontline metastatic breast cancer, the median survival is 4 years. We can't wait 4 years to know the answer. One fallacy of that argument is that you don't have to wait till median survival is reached to detect a significant OS benefit. You can often detect it far sooner than the median. In fact, some fields, they have had many trials with OS benefit. They've never ever seen the median, like cardiology. Oh, shoot, hold on. They've never seen the median, like cardiology. I think OS, and we've done some studies like we published where we estimate how much time savings there is from surrogate endpoints. I think it's overstated. Even response rate is overstated, because response rate, people typically approve drugs based on the response rate and the median duration of response, which can be very, very long, and only in the responders, which can take a long time for drug development. So I actually think surrogates don't save as much time. And if you're curious, you can read the paper. Emerson Chen is the first author. I think it's called like Studies, How Much Time Does Surrogates Save, JAMA Journal of Medicine, that we wrote last year. But the answer to your question about drug development is, I think we can reform it. We should initially look in relapse refractory settings, and we should think about how to move drugs forward, acknowledging some of the principles of crossover. The best thing that I would advise is you should check out Malignant, the book. It's an audiobook. I narrated, and I think it will give you a different vision for how we should do drug development. Because the current, I think, landscape has a lot of challenges and problems, frankly.
Do you see any role for surrogate endpoints? I guess the other question, I know there's a lot of challenges with how they're used now. Is there any value, any situations where you think there is some value?
Well, I mean, I'm a big believer that drugs that don't have response, we shouldn't even waste our time with. And in fact, I don't know if you know this history, but there's something called latro. Latro was in the peach pit. It was a naturally occurring arsenic-containing compound in peaches. And in the 1980s, the 70s, people went crazy about latro, and they thought it was going to cure cancer. And there were anecdotal reports that it cured cancer. And Mortel used his response rate to show that in a study of 200 people who took Laetral, nobody had a response. And that was a New England Journal paper, and that debunked Laetral. And people said, well, Laetral doesn't work to help cancer. Fast forward, it's 2020. We have large randomized trials ongoing of the following things: metformin, statins, ACE inhibitor, vitamin D. These are huge randomized trials we have ongoing. I promise you, you can give a patient as much metformin as you want. Their tumor will never shrink. I do not believe it will improve OS, because I believe that, and I think we've done some work to show, that drugs that do not do not generate response are not anti-cancer drugs. And they can do whatever they want in the body. Statins can, lower your plaque or whatever, but it's not going to slow your cancer growth. And in fact, Miguel Hernan has shown that the reason we think metformin and aspirin and statins all work to slow cancer is because observational studies, which compare people who the doctors kept on those medicines to people the doctor said you don't need to take it. But that's biased, because the patient that you keep on their high blood pressure medicine is a patient that looks like they can take it. The patient who looks like they're going to topple over because they lost 40 pounds is the patient you pull off the ACE inhibitor, right? So it's really confounded by the types of people who keep on those drugs. So, okay, so to answer your question, step one, I think response rate has always been a great way to weed out drugs for drug development. Progression-free survival, if there's no censoring, if the censoring is not imbalanced, if there aren't these issues, it potentially can be a faithful surrogate. And actually, I think disease-free survival in the adjuvant setting can often be a faithful surrogate. So I think there are places for surrogates to be used. A highly lethal cancer with no options, maybe a response rate that's very durable is a good enough for an accelerated approval. But I think the reality is that surrogates are supposed to be the garnish, and they become the whole meal. Like, it's the majority of what we do.
Dr. Weisdraper has typed, I would argue it's patient selection and understanding biomarkers. Just saw a patient today who had clear response to metformin, but did not. But we don't choose well.
It's possible. But single agent metformin a response? Or race metformin plus RT?
Sorry, I'm trying to get in my car. It was actually a response. So I have a metformin plus pembrolizumab study, and we do a lead.
Oh, well, plus Pembro. Come on, Pembro. Good. Yeah, okay. Fair enough. We will learn something.
Metformin alone for 2 weeks resulted in the neck node decreasing in head and neck prior to the Pembro starting.
Oh, wow.
So, yeah, so it was actually, I have documentation of it, but the other thing that's interesting is, we think it's because the immune response of activating NK cells, not through the mTOR, which is the usual argued. But like I said, it's all about patient selection, right? I don't expect very many patients to have that response to metformin alone at all.
Well, that's very interesting. We used to run a trial in the Frau-Mani patients where we gave a lot of metformin and we didn't see anything. But I guess there's two things. One, of course, is if you pool all the placebo arms of randomized studies, the response rate is 2.7%. But at the same time, you can always be surprised. And so we shall see. I guess the story is ongoing. There are a lot of randomized studies going on, so we will know the answer. I look forward to learning more.
Defend that metformin directly, right? Because, I agree with you. Most of what we're going to find is that it's not a very good anti-cancer drug. But I do think that personalized medicine is where we have to go, because I think some patients do respond and most don't, right? So it's finding which ones respond, and those are going to be the hardest trials to actually design.
Yeah, I agree. It's a very tough challenge. We once gave, what was it called? Crolubulin or something, some drug that you never heard of. And had one responder with anaplastic thyroid cancer who responded for 13 years. And it was, the company went belly up and stuff. But I guess, I think many of us have those kind of flash in the pans that are always really tempting. Well, thank you so much for having me. Yeah.
Appreciate your time. And I think the trainees will have definitely gained something from this, and other trainees will as well once this goes online. So appreciate it.
Thank you. Yeah, thanks so much.
Thanks a lot. Take care.
Okay, take care.